Good afternoon, everyone. How is everyone doing today? Very good. So we are going to talk about advanced cone beam computed tomography interpretation. This is a very useful course or the lecture. It will be very useful in your career and in your clinical practice. If you're going into residency or you're going into private practice, especially for the practitioners, these are very good lecture for you. So the important thing here about interpretation is, taking, radiographs and everything, that is pretty good. But the real one, if you want to learn, that is about, really understanding the images and your clinical scenarios and how you can use it for your clinical practice. Let me start with a case which I saw last Monday. Yeah, this Monday. So we have a case. The patient has undergone root canal therapy in 2018 of tooth number 30, and patients undergone extraction of tooth number 32. After that, pain and swelling, everything happened, and they were not so happy about it, this patient. And then patient also consulted dermatologist because there was electric, sharp pain there, and patient also lost, there's also dysphagia. And there were a lot of issues going on, and he also went to ENT and checked other areas of his head and neck region. So basically, we don't know what's going on. So we took a CBCT scan and we saw a nerve injury on the right side. So let me show you from the beginning the story of this case. So they took a pan in 2018. Saw tooth number 32, which is impacted, and they want to see how the canal goes. And they thought the pan is good enough, and then they decided to extract it. And once they extracted the tooth, that area hardly heals. Even after 1 year, in 2019, this patient have a lot of pain. So it was not showing clearly on the pan, and they took periapical radiograph. In the periapical radiograph, you can see the posterior area is not so nice, right? You cannot see, but you cannot really see that area. So it was referred to our endo specialty, and endo took a CBCT scan, and then they thought, maybe something could be wrong from number 30 or 31. And 30, they have done a root canal on number 30, and number 30 looks pretty good. That's very nice. There's no periapical pathology. That looks nice. This is the axial view. This is a sagittal view, and there's a coronal view, and everything looks very good here. And they went to check the number 31. 31 also looks good. There's a little bit widened PDL space. Other than that, 31 also looks fantastic. And the canal along the 30 and 31, that looks pretty good. And we took a CBCT scan in 2020 because patient has electric pain and those things. So I really checked through this Monday. I went through that area, and I saw there's a branching of the right mandibular canal in the superior direction. And this is a canal goes all the way, and there's a branching of canal superiorly. And I went through the scan, and I checked. This is called the MPR view, which is the multiplanar reconstruction. Please review your previous slides to know the CBCT views. So here you can see, there's a root tip which is left behind here. And okay, you can see the root tip here, and the canal kind of goes like this in this area. There's an axial, there's a sagittal view, and there's a coronal view. And I try to focus that on root tip. You can see all the root tip here, and also as well as here too on all these images. Now, when you look at this canal, I try to look at the canal. I make a section on the CBCT scan, where you can see, that there is a superior. You can see the canal goes superiorly, and there's a branching of the canal that is not so good. So that's where the nerve has been injured in that area after the extraction. And I asked the patient, how was the extraction? He said it took at least 5 hours to finish the surgery. And the patient has to actually tell, I cannot do it anymore. So he left. So, when they took the tooth out, what happened was the number 32 area, you can see that the root tip is left behind. They saw the root tip is missing. They knew it's inside the socket. They tried to, take it out. While doing that, they were actually injuring that nerve in that area, which they missed in the pan. So pan is very deceiving. Make sure you have a CBCT scan and evaluate everything thoroughly. So I traced the nerve canal, and the canal, this is the mandibular canal, this is the mental foramen, and right at the number 32 apex area, the canal kind of goes superiorly and kind of loops, towards mesially. And on the left side, the canal looks fine, but on the right side, you can see, and that's where this nerve was injured. And because of that, you can see there is a pain, sharp pain, and this canal was, injured badly through the extraction. Yeah, and then you can also see, and these are called cross-sectional images. In the cross-section, you can see the root tip here, and also you can see the branching of the canal superiorly direction. So you have to be very careful, take the tooth out. So make sure you evaluate your CBCT scans thoroughly, and then you can go for it. Now, these are the 7, signs of a radiographs. You should see the, bone density there, where you can see the bone quality and how the trabecular bone is healing or not healing based on the extraction or root canal therapy you have done. And also the margin characteristic, how the margin looks like, and if there's a lesion, what kind of shape the disease has, So these things you can check. Also, where the location of the lesion is. If the location is a critical vital area, like we have in the mandibular canal or in the posterior superior canal or other areas, and the size of the lesion too. And the internal architecture, suppose you have a pathology there, and how does that pathology resembles, how does the pathology shows? And if there's a pathology and how it's affect the surrounding structure, is it like resolving the root, or it's pushing the root, or displacing the root, or is just perforating the buccal and lingual cortices? So these are the valuable information from your exam point of view. I may ask, what are the radiographic signs, and please make sure you know 7 of them, and you select the right ones based on the questions asked. So radiographic interpretation is, it is the ability to see, what are the disease there, what is normal, what is not normal, and then, and based on that, you can see that. Nowadays, I get a lot of requests for doing the CBCT CE and for implant, for pathology, for extraction, and so many purposes. The first thing I teach them is you have to understand what is normal and what is not normal or abnormal, and you have to differentiate between these two very nicely on your 3D imaging. And the second one you have is the radiographic signs and symptoms of those things. So you have to make sure that the radiographic signs and symptoms and if there are any previous images, please use them too. And also follow the symmetry area. If the left side is not matching with the right side, then something is wrong in the radiograph. So make sure everything is matching. If you see any irregularity or abnormality, then where the problem is. And also use the right term. In CBCT and CT images, please use terms like if it's dark, then you can use hypodense. If it's bright or radiopaque, then you can use hyperdense. So, and if it's like in between, you can write heterogeneous area. You can say that. And finally, you can categorize the disease based on your needs. So you have to categorize the disease in the end. That'll be your final thing. So basically, it's like a language. CBCT interpretation is a language of 3D where you can, it's one of the languages you have to know, and that's where the images will help you for implant placement, surgical guides, or pathology detection for endodontic purposes. Whatever you want to do, it'll help you. So you have to make sure that you know this language well, and the basics of this language starts from this lecture. And it was a long-term request from the school, where we really have to get this new course going, and I took the lead in running this course. Hopefully it helps everybody. So for the interpretation purposes, you have to know the principle number 1. You have to make sure that you know the normal anatomy. So this is the 2D image of your bite wing. This is tooth number 2, 3, 4, 5, 6. And on your pan, you also know 2, 3, 4, 5, 6. Based on that, on CBCT scan also, you have to know which tooth number 1, 2, 3, 4, 5, 6. CBCT also you have to know. So in the CBCT, I just want to tell you, this is, they want to evaluate the airway, and that's why you can see that. And this is the sagittal view, and here this important anatomical structure where you have this pterygomaxillary fissure, where this the important nerve structure and the plexus goes from this area. And this is the coronal view. This is the medial pterygoid, and that's the lateral pterygoid plate. So you have to know that. And the interpretation number two, the principle number two, is about you have to talk about whether the disease remains the same spot or not. Also check for the area where disease. So where you have to know whether it's disease or not. And this is the CBCT volume rendered images, and this is your 2D image PA, and that's a lateral ceph, and that is the pan. And from your CBCT, you can reconstruct or make your own lateral ceph and your panoramic radiograph. Also in CBCT, if there's an area there you want to check for implant placement, if you want to see the bone height, bone width, you can easily check it by using your cross-section images. In this case, we were thinking, oh, they may have not enough bone, but we went through the CBCT scan, we really measured it towards number 19 area. We have enough bone, we have good bone and good width too. So we decided to place an implant in this area. And this is a machine we have in our school. So this is called Carestream 8100. This is great for your endodontic purposes, seeing 2 to 3 teeth in a very high resolution, where you can see the root fracture, or you can see how many canals are there. If somebody has sent you a case and the case is failing, and you found the reason through that missed MB2 canal or fractured canal, you can really see that. Now, this machine is the iCat FLX, that you can use it for your major purpose, for the orthodontic purposes or surgery purposes, and for your and for other major big purposes you can use it. And the third principle is it's about symmetry, which is very important. Please check compare the right side with the left side. And here, suppose if you are looking here, this is a coronal view. You can check it from the right side to the left side. If it's a tooth, how does the two premolars looks different? How does the two molar looks different or equal? You can check based on that too. And this is the axial view. You can also check in the mandible. This is the buccal side, and this is the lingual side. And you can see how this lingual side is different from this side. In this case, looks pretty symmetric, and that is a normal sign of this area. And the other one you can see is this is something very important. If you have your patient, previous information, or there's any previous history or signs and symptoms, those are very useful. So you can always use them. Please use your previous radiographic images. They'll be very useful, and existing radiographs. And then only you justify if you need a CBCT, and based on that you can go for your CBCT scan or any other radiographic images. So this slide I really like, because they talk, every time I give and present, they say this slide is something they really like it. So first you have to know whether it's normal or abnormal, and if it's abnormal, you found it, you have to make sure whether it's a developmental or congenital, and then you can also check whether it's acquired, in its lifetime, whether it's trauma or inflammation, and then you can categorize whether it's a tumor or cystic lesion or fibrosis, or systemic or metabolic. Based on that, you can make your impression and move ahead with your treatment planning. So this diagnostic part will really help you in making your treatment worthy of it. So I told you the fourth interpretation about the CBCT is CBCT is a language where you have to learn how to interpret 3D images, and there are some descriptive terms which I will go through. So if it's these are CBCT reconstructed from a pan. If there is a radiolucent lesion in the jaw, you have to call them hypodense. You can see that area. That's where areas, the hypodense area or the radiolucent area from pan. And you have also know terms like corticated unilocular radiolucency. That means mostly like cystic area with cortication, well-defined cortication around it. Non-corticated radiolucency, which is the cortex is gone, the covering of the lesion is not there. And the multilocular, this is there, but the lesion is in various multilocular fashion. You can see that. And the other one is multilocular confluent radiolucency. That means there's multilocular, but it kind of like attaches and sticks together with to one another. You can see that. And the last term is the moth-eaten appearance. That its appearance looks like moth-eaten appearance. So it may look a little bit, irregular, and margins won't be clear. So these are some of the examples of you can look in your radiographs where you can see if it's a unilocular radiolucency, you can see very well defined in this picture. It's a round, well-defined well-defined, radiolucent lesion here you can see. And this is a pan, so you can also see the same thing, well-defined round radiolucent lesion. You can check that. And the second one, this is an example on the CBCT where you can see on the anterior mandible. This is the anterior mandible. There's a round, well-defined cortical area, and this is also, you can see round, well-defined area. And the beautiful thing about CBCT is you have cross-sectional images where you can actually check exactly whether it's from this is the buccal side. There's a lingual side, and you can see it's well-defined, corticated. And it's beautifully, it's sticked in there. And there's the buccal cortex is thin, but it's not perforated. You can see it's thin and it's expanded, but it's not perforated. Same goes to the lingual cortex. So this is the buccal side, is lingual side. So yeah, so you can check that the lingual side is intact and buccal side is intact too, but it's a little bit expanded and thinning of the cortex. You can see. Another example is the unilocular radiolucent lesion with the non-corticated lesion. That means their cortex is missing. You can see this, non-corticated area. So there's no circular area here. Everything looks non-corticated. In this case, mostly you can think of inflammation, or if they've done a root canal. If the root canal is healing, then you can see this area there. The periapical scar tissues looks like this. And the next one is the multilocular radiolucent area. You can see there's multiple locules in that area, and these are called multilocular radiolucent area. And you can see that in the cystic area. This is a case of immunoblastoma where you can see those multilocular area in those area. You can also see the root resorption expansion, and you can see multilocular area all over the ramus, superior portion of the ramus area. Yeah, you can see that. And this is yak. In the Himalayas, they have, nice yak. These yaks are very useful. They're very helpful and kind. They will take your luggages. They will help you, and they give you, milk. They give you wool, and they give you, if you want to eat, you can. They have food, but yes, they're very useful and very, good animal in the Himalayas in rough winters. And another example of multilocular, you can see there are multiple locules in this area, and you can also see there are multiple locules with root resorption. And this is a occlusal radiograph where you can see multiple locules in the area. Same thing goes here, multilocular occlusal radiographs. You can see it. In the periapical radiograph, the multilocular, kind of looks like this. They're separate multilocular. You can see different. These are multifocal, radiolucency. These are just at the apex, and it's focal. You can see that. These are multifocal radiolucencies. And I was trying to use this term called confluent, multifocal confluent radiolucency. See, the radiolucency kind of, attaches with each other, touches with each other. These are the confluents of radiolucency. Excuse me. You can see that on, on the cone beam. You can see very beautifully in those areas. And these are the 10 cross-sectional images of the cone beam where you can put cone beam. This is slice 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And there's the buccal side and there's the lingual side. You will see exactly whether there's expansion, erosion, or bone is not healing. You can see that too. These are multifocal confluent radiolucencies, you can see. And it's a moth-eaten appearance, as we discussed before. Margins are not really, well defined. You have to actually, little guess here, which I don't like it. So if it's like that, then these are like moth-eaten appearance in this area. In the mandible, you can see that on the pan too. And the next one we have is the unilocular corticated radiolucency. You can see in the pericoronal area, you can see that cortication around from CEJ to CEJ. This turned out to be dentigenesis cyst. Also, you can see that area, from CEJ to CEJ with the impacted tooth. That is the, dentigenesis cyst. So you can see that very nicely here. And here also you can see CEJ to CEJ goes all the way up. So this also turned out to be yeah, this turned out to be OKC in this case. So here we followed the radiographic signs using the abnormalities of this area. Now you have the radiopaque lesions. You can see these are CBCT scanned in 6 different slices, where you can see the tooth is being impacted. On top of that, you have a lot of thick bone going around it. So you have to make sure what this is and how the lesion shows. So the terminology is radiopaque area or hyperdense area in CBCT scan. And some of the other terms will be, focal opacity, target lesion, multifocal confluent radiopacities, irregular, ill-defined radiopacities, ground glass appearance or radiopacities, mixed density radiopacities, or soft tissue opacities. So we'll go one by one. So you can see focal opacity, where you can see, it's focal and it's opaque. So it is a case of cementoblastoma, where you can see this, nice, focal opacity at the root apex. So yeah, and this is this also you can see here. So so you can see focal opacity in this area. And another one is a target lesion, where you can see a target-like area. You can see the target. This area is where there's a supernumerary tooth, and the root is facing towards you, and you're actually seeing the pulp canal through it, and that's how it looks like a target area. And there are other areas. This is a case of odontoma, compound odont. It looks like compound odontoma, where you can see all this tooth here, and you can actually count them. So these are the target area, and based on that you have your own definition. And this is the multifocal confluent radiopacity. It looks like this multifocal confluent. It goes all the way and confluents with each other. You can see that in the mandible, and these are CBC reconstructed pan. You can see beautifully here too. And the next one, you have irregular, ill-defined radiopaque pattern. Whenever I hear this term irregular, ill-defined, I don't like it too much. That says mostly goes towards either inflammation or malignancy. So in this case, it turned out to be osteosarcoma. In this case, you can see on the on the right mandible, on the right mandible, you can see there are a lot of areas of sun ray appearance and irregular, ill-defined radiopaque patterns or hyperdense area in those areas in the mandible, I would say. And the ground glass appearance, you can see the appearance of a ground glass. Some people also call it orange peel appearance. So you can see that the maxilla, you can see ground glass, but it's not so clear on the pan. Pan is kind of deceiving, so you have to make sure you get a CBCT. So this is a beautiful harmonious relationship between a dog, a cat, and a beautiful cat. See, they all look very cozy, very happy together. I think a human relationship, if it's like that, that'll be wonderful. That's awesome. These beautiful creatures are amazing. And you have this ground glass appearance, orange peel appearance. You can see more like a ground glass orange peel appearance. That's why you see. And based on that, you can have your own disease diagnosis, like fibrous dysplasia. You can think about, this is a case of fibrous dysplasia. This is on the PA. This on the this also on the pan, which we cropped it, and this is on the occlusal radiograph. You can see that. And mixed density lesion, you can see there are lesions with mixed calcification or lesion. Whenever you hear the word mixed, that means the lesion is producing some calcification. So you can see that the lesion is being produced in the right mandible. And now this is interesting. This is axial, this is sagittal, this is axial, this coronal, this is sagittal. So you can see mixed density lesion where the lesion is producing some sort of calcification in this area. So these flecks of calcification, so these turn out to be, fungal infection in the sinus, aspergillus, those fungi. You can see that those infection in the biopsy shows, fungal infection. So you can also see those area too. Now, the other mixed density you can see in the maxilla and zygoma area. This is the area where you have all these important structures, So you have to also know what are structures you see here too. And if there's, you can see there's, inflammation or there's malignancy. In this case, more like malignancy here. So you have to really know what's going on in this area. So whenever you have, malignancy or fungal infection, you tend to have in fungal infection, you tend to have calcification with hypodense area. And in the tooth structure, you can see, you can see a tooth with a well-defined cortication, and there are some areas of calcification surrounding it. So most of the time, they turn out to be calcifying epithelial orogenic tumor, or they also call it pink bird's tumor. And the other one, you can see mixed radiolucent lesion in the pan. You can also see, mixed sensitive lesion around the tooth. These turn out to be, adenomatoid orogenic tumor. And that's something you can see here. You know, also the calcification, this calcification you can see. Just want to show you and correlate. So this is amazing. This is a picture of dog, and I really don't know whether this is dog or cat or leopard or tiger. So that's a very beautiful, I think, giving personality or giving nature of this dog mother. That's beautiful. It's a very beautiful picture. That's awesome. So that the interpretation principle 5 is about the category of the disease. So once you know it's abnormal or normal, in this case, if you know it's abnormal, you can see whether it's coming from acquired, trauma, inflammation, or it's from a tumor, cystic, or fibrosis lesion, or metabolic. Based on that, you can make a differential diagnosis or come up with the impression and move with your treatment planning. The other one you have here is the type of dental anomalies. So we can check the number of teeth based on that. If you have too many of them extra, we call it supernumerary. If it's extra, you can call it mesodense. If it's less, hypodense. Like that, you can go, and also depend on the size of the teeth. If the size big, we call it macrodontia. If it's small, it's called microdontia. And also you have the form of tooth. You can see whether it's germination, twinning, or fusion, or tarantism, or you can see dentin vaginatus or dentin dente or dilaceration, which you will see in the coming slides. And also you can see how the eruption of or the position of teeth looks like. You can see whether it's transpositioned or whether you can see it's ankylosed. So you have to really know whether, if there's supernumerary teeth, you can actually see, count the teeth. If it's extra, if it's in the middle, you can say it's mesodense. If it's somewhere else, you can call it supernumerary. So in CBCT, it's very useful, especially for the orthodontic purposes. People will send cases to me and they say, Dr. Rule, can you please check at the, area, at upper area? I want to check before I do any treatment, so I can check and see if there's any supernumerary tooth or missing tooth. Based on that, they will it really help them with the treatment planning. And germination also, you can see so you can see the example of germination here very beautifully on this picture. And let's go next. You can see dentin dente. You can see a tooth-like structure, enamel tooth within the tooth. That is a dentin dente. Not so good, because if the food gets impacted here for a long time, this may undergo root canal therapy, I'm sure. So you can see the apices you can see a big pearl here, and there's a root resorption and tooth-like tooth structure here. So you have to do a root canal for this. So Detroit is famous for its, Ford Motors is a motor city. So these are the, first patent car, automobile, which was introduced in 1885. So that's interesting, patent motor car. And then this model, Ford Model T Touring, became pretty famous, and this is one of the largest sold models in the whole of United States and Europe too. Now, for orthodontic purposes, the question here is, how many, supernumerary teeth you may see here. Yeah, it looks like it's here. You can actually count 1, 2, 3, 4, 5, 6, and then 7, 8, and then what this is 9, 10. This is supernumerary, and likewise you can count. And if you have a CBCT, you can actually see them. You can actually see here. There's one here, and you can see actually it's going. You can see it's horizontally placed and it's coming more towards. You can see it's going backward. The crown is facing inverted, right? Backside. You can see that. This is first supernumerary. And there's another supernumerary in the same area where you can see one supernumerary here, another supernumerary here in this area. So CBCT is very useful in detecting those supernumerary tooth. Also, if you have a paramolar, you can also see the paramolar here on the upper right posterior quadrant. And these are the paramolar area. You can see through that. And the other two paramolar you can see on the left quadrant. These are CBCT reconstructed pan where you can see everything. And this is the this is the axial view. In the axial view, you can see these two. You can see the paramolar here on the left side. And if you have a dilaceration and everything, you can see that in your pan and also in your CBCT. You can actually check the dilaceration here. But the good thing here in CBCT is if you want to extract this, is causing some lesion or denture cyst around it, you can actually trace the canal inferior canal, and you can actually tell the oral surgeon how to take it out. And if you're taking it out, you can really plan it well and really can take it out well. And there's a unilateral radiolucency. You can see, how would you describe this lesion? So you can describe well-defined corticated, radiolucent, entity superimposed on the root apices of number 20, 21, 22, and just above the, mental foramen. So you can see, and the canal and the lesion has not involved the midline. If you describe like that, that's pretty good. And if you can see, you can also show the, condyle. If you check the condyle, this is the right side. Left side looks pretty good. Left side is, pretty big compared to normal. Is hypoplastic or bigger, so that's why they call it hypoplastic condyle on the left side. And this is a case of hypoplastic condyle. Now, beautiful thing about the CBCT is when you place it on the condyle on the left side, you can actually see whether it's really big or not. So you can see the condyle on the left side pretty big, it's sclerotic, and yeah, you can see, this turned out to be, osteochondroma. So they are pretty big condyle, and based on that, you can come up with your diagnosis too. Some of the abnormalities you can also see: dentinogenesis imperfecta, dentin dysplasia, regional odontal dysplasia, enamel hypoplasia too. You can see. So you can see, the dentinogenesis imperfecta. You can see partial incomplete obliteration, pulp chamber, constriction of this cervical area, and the crown APS bulbous, right? And you can see crown APS bulbous. It matches with the other description, which is the cervical constriction here. Also, the roots are short and slender too. You can see that, and you can see generalized all over, right? There is a dentinogenesis imperfecta. Nice. And dentin dysplasia, they have two types, right? Type 1, type 2, and then type 1 has short roots and conical shape, and sometimes also known as rootless tooth. So if you see rootless tooth and a conical shape, you call it a dentin dysplasia radicular type. That is type 1. And type 2 is a coronal, which have normal roots, you can see, but have a flame-shaped or turgle or flame-shaped, pulp canal. So you can see the flame-shaped pulp canal. That is the type 2, which is called the coronal type. And the CBCT is pretty useful for seeing the impacted tooth. This is the buccal side, and this is the palatal side. Here you can see one tooth just next to this central incisor. And good news is you don't have root resorption here, so you can see whether there's root resorption or not. You can actually customize tooth by tooth, and you can plan your treatment based on that. We came a long way, from Ohio. Ohio, the Wright brothers came up with the first, airplane, and then you can see, first plane you can see, and then now we are going to other planets to, and also to other stars, moons, So we are really, figuring out, and we are really update our game. So it's very interesting. The message here is people are watching us, and we have to make sure that whatever you do, it's done perfectly based on the diagnostics, based on your CBCT scans, your 3D imaging skills, and everything. Now everything has come into action. If you miss something, we can see everything. So in this case, I may ask you, okay, how does this canine looks like? This canine, you can see it's like a submarine here. It's like kind of hidden here, so you have to know this too. Now, if you take a CBCT scan, you know exactly whether this canine is coming buccally, lingually, or how it's going, this position of this canine. So that's very useful. And if you have a cleft lip, cleft palate, this patient, I just saw it today. So where you can see there's a cleft lip, cleft palate here. Unilateral cleft palate goes all the way from, this is the anterior, that's posterior, goes all the way. And in this case, the patient has also undergone surgery of the soft palate, which is attached. So when the patient breathes through the mouth. So that is very interesting here. This patient has tried to commit suicide because the patient doesn't look good, and also since patient is a mouth breather, so they have a lot of issues with that. So we are trying to schedule this patient as soon as possible to help the patient. And you will see, you have to know in cleft the hypodense or the radiolucent area runs all the way from anterior to posterior. Whether if the bone is involved, you will know in this area you can see there's a cut in the bone. That means the bone, there is a communication through this nose. But because of that, you can also see the sinus being inflamed in that area. So this gives us a lot of information. And also in the cleft palate, you see, the nose kind of looks more flat because the bone is not there at the base. The nasal bone is broken, and that's why you see the nose, flattened, and the anterior maxilla is deficient also. So that these are some of the things which you don't want. You can also see that in the coronal view there's a big communication all the way from palate to the nasal floor, which is not nice. And you can also see, in CBCT volumes, if you want to see the area here, this looks more like ill-defined hypodense area, and surrounding bone looks pretty thick, and that doesn't look good to me. This turn out mostly, either inflammation, in this case inflammation, and you can also see there's a thick bone surrounding it with sclerosis. These are the chronic osteomyelitis cases, which you don't want. Also, you can see in this case chronic osteomyelitis, and through this push towards the buccal side. These are called a buccal bifurcation cyst. So you can, based on that, you can give a lot of information and can really help your patient. Yes, 2D is great for seeing the root fracture and everything. You can see the root is being fractured here. That's good. You can see that. If you see, I'm saying good because you can actually now go to the next level and you want to place implant once the entire bone area is healed. Now, when you go here, you have this one. This is the axial view where you can see these are left max sinus. It's broken. The sinus has full inflammation inside, and it's very aggressive and destructive. This turned out to be squamous cell carcinoma malignancy, that left max sinus. And if you have a CBCT, if you want to see the fracture of the bone, you can see the fracture segment here. We don't like this, so you can see 2D is good too. You can also see root resorption, everything, but CBCT gives you millimeter by millimeter in right spot. And always I appreciate the 2D images too. If there is any previous old signs of trauma, you can see pulpectomy being done, also the widened PDL space, and also check whether the tooth, all the teeth are splinted together or not. You can see teeth are being splinted. That means that there are signs of old trauma even by 2D images. You can see in 2D images, if you want to see, there's a root resorption you can see, and also there's a horizontal fracture you can see. Also, you can see the fracture here, and also oblique line fracture here. So based on that, your treatment plan will change, your game will change. If you have a CBCT scan, you can actually use, and you can actually tell one by one. Yesterday we have one patient where we have a root fracture on the palatal root. So we actually found out through the CBCT scan, and fracture goes all the way. This is from the anterior, but that's fine. The oblique fracture shows like this, and based on that, your treatment plan also changes. Let me check that. I hope you can see that. Okay, there we go. So let me check that area. Okay, good. Excuse me. Okay, now another one we have is the alveolar bone fracture. If there's a dentoalveolar fracture, you can also see the alveolar bone fracture. In young female, in young male, is pretty common because male tend to play more than females. But now everything is equal, so anybody can have it. So we cannot guess it. So based on that, you can see the dentoalveolar fracture. Also, you can see the fracture line here, and you can see IMF, intermaxillary fixation, being done in this area. So you have to make sure you see everything, dentoalveolar fracture, tooth fracture, everything together. If there's a cyst or something, you can also see. We just thought that there's a fracture here alone, but if a CBCT, you can just put a cross section here, and behind that, this is the buccal side. That's the nose, and that's the palate. That's the tongue. Towards the palatal side, you can see there's a well-defined hypodense area with cortication. There's a cyst on the palatal side of that fracture, so you have a cyst too, not just a fracture. So beetles in early 1960s, they become very famous and popular. A small amount their EMI money went for that CT research, where CT was very new and people don't know how to use 3D imaging and those things. So Hounsfield, an engineer from England. He worked on CT scan machine, and he received a Nobel Prize in in making CT scan. So that is very interesting how everything is interrelated, and based on their small profit, which is the company is called EMI, and based on that he received a Nobel Prize in creating CT scan, and it changed the phase of medicine. Now it's changing the phase of dentistry, and whoever learns early gets to enjoy the most in clinical practice, and it has already started. And here we have a patient where you can see patient undergone extraction, and on the pan you cannot see really much, but the patient has pain and they want to see what's going on in that area. So we took a CBCT scan, and when we took a CBCT scan, you can see after some time the scan was taken after 2-3 months, because patient came back and said, the pain is not going away and it's very painful. And when we saw that, we saw that fracture line which goes all the way, and it became chronic, and it became there you can see the extra bone or periosteal new bone formation. Whenever you have new bone formation in that area, it is called chronic osteomyelitis. You can see on the axial view, you can see a lot of bone there. So at the time of surgery, it was broken and they missed it, and the patient has to pay a very heavy price for that. So you can see there's extra layer of bone. They call it periosteal reaction in that area. So whenever you see something like that, that means there's a chronic inflammation going on. So there's a fracture after that because of the inflammation, pathological fracture too. And CBCT is pretty good for seeing the external root resorption too. So you can see the root resorption, everything you can see. And I just want to show you here, just know that you can see the root resorption from here. And so you can see that one, and you can go next and you can check, if there's internal resorption from the exterior, you can exactly see it's coming from the, pulp canal, not from the outside. So you can really differentiate based on it's coming from internal or external. So this one comes from inside and goes outside, inside and outside. And for the people who are interested in oral surgery and in fracture management and surgery stuff, you can also see if the fracture is broken, if the condyle is broken from the condylar neck, you can see condyle neck fracture here. Also the maxillofacial fracture also you can see. And pan is also good to see the fracture. Sometimes it's deceiving. We may miss fracture too. One of the oral surgeons I met about 5 years ago, he missed one. A very good friend of mine, so he always advised me, never miss any fracture. It's not good for the reputation, for your practice, and also for your colleagues too, and definitely for the patients. So you can see mandibular fracture is the second most common fracture of the, after the nasal bone fracture, and you can have that, fracture the body, angle, and the condyle area. So based on these percentages, you can see. Just know that there is a fracture. This percentage and everything I will not ask in the exam. So just know this thing comes. Always make sure you compare it with the other side too. Okay. The only two things you have to know is whether the fracture is favorable or unfavorable. Favorable means fragments come together, which are more easier to fix it. Unfavorable means muscle kind of pulls it, here and there, and that's where it's become a little tricky. Now you have to pull it back and fix it back. In this case, this is a favorable fracture where you can see a hairline fracture on the CBCT scan, and it actually is not just the fracture is not just on this side. Patient had a blow on the right side, and you can also see the fracture on the anterior mandible too. So this is not a good sign. So you can fracture on the angle of the mandible, also on the just next to the canine tooth number 27 area. Fracture goes all the way towards the inferior border of the mandible. Now this is important. Whenever you see fracture in the condyle tends to move. The condylar head tends to move more towards the mesial direction because of the pulling of the lateral pterygoid muscle. Please remember this is an exam question. So fracture goes in the condylar fracture goes more towards the mesial because of the pulling of the pulling of the condyle portion towards the mesial side by the lateral pterygoid muscle. And also whenever you have this patient, I tell you a story. This patient, he got hurt on the got hit on the mandible. And whenever they got hit on the mandible, the condyle also got hit at the same time. it pushed it and it broke both the mandible and the condyle. That's why you see that too here on the pan. Now you want to see the trauma in the TMJ area. You can see pan is pretty good. You can also see the flattening, but if you really want a good, nice diagnosis, you need to have a CBCT. So people say, what is there in Detroit? In Detroit, we have, the first HIV/AIDS medicine was made by Dr. Horwitz from Wayne State University. Dr. Horwitz, he is also an alumni of the University of Detroit. So he did his bachelor's and master's from our university, and then did his PhD from Michigan University, University of Michigan. And his HIV medicine is the first approved FDA-approved HIV medicine. He's the reason why people live for more than 40, 50 years, and he's a great guy from our product. And another good institution in Michigan is University of Detroit Mercy, where we are here right now. If you have a previous trauma, you want to know on the lateral ceph, you will know there's a flattening and there's a little bit of osteophyte formation in that area. That's pretty good information, but it doesn't give the entire information. So you have a CBCT scan. If you have a CBCT scan, this is a TMJ view. If you want to see the previous trauma, usually the conda, these are conda on the right side, conda on the left side. Left side pretty big and looks more like a camel or like crocodile face, camel hump. Camel, you can see the camel head. So you can see that it got broken, and the muscle pulled it more towards mesial and got healed naturally, and that's how now the future shape looks like. In this case, it's nature is amazing, because if you get hit on the condyle, if it goes all the way up, it may go through the brain, right? The patient may die. But the good thing is the neck of the condyle always, most of the time, breaks, and and the lateral trapezoid muscle pulls more towards the medial direction. That's amazing how I look and think about it. If there's a zygomatic fracture, you can see the fracture zygomatic, right zygomatic, one fractured, two fractured, three fracture. You can see the fracture. And when you palpate that, there will be a depression in that area, because now this bone is broken. When you palpate, your hand or your finger will go towards the depression. And sinusitis, whenever in CBCT, is great for seeing the sinusitis. You see that sinus, the right sinus fully filled by the inflammation in that area. You can see sinus being filled in this area, right side, right side, right side. And that's also a very good information. If you want to see the extraction site, if there's an extraction site, the previous extraction done, you can also see on your pan, also see on your CBCT. But I would suggest you to look at CBCT more. And this is a case of patient have undergone extraction and left it and came after 3-4 months, and patient have a lot of pain, and patient said, actually, my left jaw's paining, it hurts a lot. And when we look at check there was a pathological fracture in that area, because the sterilization, everything was not good, or patient didn't take care of it. It broke, and there's a pathological fracture on the left mandible. If there's a sinus procedure done, if you don't use CBCT, you will see, once you check it, you can see sinus leaf is not done. You can see there's communication from oral cavity to the maxillary sinus. The communication, we never want to see these things in the sinus leaf procedures. So you will see actually the inflammation, everything, even after you do the surgery. And if you the patient says like, oh, it's not comfortable, it hurts a lot, always take a CBCT and evaluate that area. And this is about, this is a beautiful image where, there's a lot of heavy lifting. You're in DS4, now about to finish the, dental school. I'm very happy for all of you. But still, I think if you learn CBCT, it'll make your life much easier. Otherwise, you have to work very hard. So please learn CBCT. That will make your life very easy. In osteomyelitis, is a case of osteomyelitis where you can see the bone changes. There's a sclerotic bone changes, and you can see there's a pathological fracture there, and bone has become very sclerotic. And you don't like these things because there's a delayed wound healing, and also patient may have a pathological fracture in those areas. And you can see the lingual cortical plate and the buccal cortical plate is being fractured because of the pathology in there. So whenever you must be thinking what kind of treatment we can give for these cases. You may give IV antibiotics, and in the hospitals they give it. In this case, oral antibiotics hardly works in this area. So you can also see this is the lingual side in the axial view. There's a fracture on the lingual side. The implant failed. They took it out, and that's how it started. And that's the area where implant failed. And we don't want this stuff to encounter in our practice. So we don't want to see this kind of pathological fracture after our treatment. And here you can see the extracted number 19, and you can see you cannot see much on pan, but when you look at the CBCT, you can see that there's a fracture, there's a segment, dead bone, which we call it sequestrum, and also the infection is also, patient also have numbness and loss of sensation in that area. So this became a lawsuit case, and you can see because of the inflammation, the canal and the canal was also involved, and patient have permanent loss of sensation in that area on the left side. That's very sad. So please use your CBCT and use it for your interpretation purposes before you use all the information. So for today, it's good. So I wish you a happy weekend, and thank you so much for your patience and for going through.